Okay, our first presenter today, well, we actually have three. They're three of our very own physicians from our Department of Psychiatry and Behavioral Medicine. We have Taya Johnson. She's a child and adolescent psychiatrist, assistant professor of medicine. She's a native of Louisville, Kentucky, where she completed her undergraduate and medical school education at the University of Louisville. She completed her adult psychiatry residency training at the University of Miami, her child and adolescent psychiatry fellowship training at the University of Louisville, and then her forensic psychiatry fellowship training at the University of Cincinnati. She is currently board certified by the American Board of Psychiatry and Neurology in Psychiatry, Child and Adolescent Psychiatry, and Forensic Psychiatry. Then we have Catherine Kerr. She's an MD. She was born and raised in Texas, where she completed her undergraduate education at UT Austin and her medical education at UTMB before moving to Lexington, Kentucky, to complete her residency training in pediatrics, general psychiatry, child and adolescent psychiatry at the University of Kentucky. Dr. Kerr moved back to Texas after finishing her residency in June and joined the faculty here at UT Health Science Center at Tyler in the Department of Psychiatry and Behavioral Medicine in September of this year. And we have Dr. Jamon Blood, who's a DO. He grew up in East Texas, about 30 minutes from Tyler. He attended medical school at Kansas City University of Medicine and Biosciences. He completed general psychiatry residency at the University of Texas Health Science Center at San Antonio. Dr. Blood then completed his child and adolescent psychiatry fellowship at the University of Texas Southwestern. So please welcome Dr. Johnson, Dr. Kerr, and Dr. Blood.
Thank you. Sorry, I'm trying to get the slides up, struggling just a little bit, of course, today. Okay, can we see the slides?
Yes, Catherine, we can.
Yes, we can.
Perfect.
Are you ready to start, Catherine?
Yes. Sorry, do you want me to start on the first slide or?
Yeah.
Okay. Nope, I'm too far. There we go.
All right, so our presentation today is suicide screening and assessment in pediatric primary care clinic. And Dr. Blood, Dr. Kerr, and myself, Dr. Johnson, we will be talking about how about this topic with suicide screening and assessment. So today's learning objectives are understand the epidemiology of suicide and non-suicidal self-injury in children and adolescents, identify tools that can be used to screen and assess for suicide and non-suicidal self-injury in the primary care clinic, and then to learn about CPAN, the Child Psychiatry Access Network, and understand how CPAN can assist primary care physicians dealing with suicidal children and adolescents. So why is suicide screening and assessment important? Before we get into the epidemiology, let's go through some definitions just so that we can all be on the same page. So suicide is the death caused by injuring oneself with the intent to die. Suicidal ideations are thinking about wanting to kill oneself, but they may or may not have thought about the details related to how they want to kill themselves. A suicide attempt is when someone harms themselves with the intent to end their life, but they do not die. And then non-suicidal self-injury is the deliberate act to cause harm to one's own body without the intent to die. So national trends in suicide from 1999 to 2018, suicide rates have steadily increased from 10.5 per 100,000 to 14.2 per 100,000 for all age groups. And this graph is just pretty much showing us that, that there's been a steady increase of suicide rates. It breaks it out into males. That top line is for males, the middle line is for total, and then males and females, and then the bottom green line is for females. And so as you can see, the slowly increase in suicide rates from 1999 to 2018. According to the CDC, the 10 leading causes of death by age group have shown that in the age group of 10 to 34, so 10 to 34, suicide, the green boxes, is the second leading cause of death in that age group. So when we're talking about, adolescents, we start at the 10 to 14 and then 15 to 24-year-olds. But I also want to make sure that you all are aware that suicide is the second leading cause of death of the age group of 25 to 34-year-olds as well, even though they're not considered, children or adolescents in that age group. And so the suicide rate for 10 to 19-year-olds had declined between 1999 and 2007, but then there's been an increase from 2007 to 2016. And in 2011, suicide bypassed homicide for the second leading cause of death in 10 to 19-year-olds. And so unintentional injury remains the leading cause of death for this age group, but now suicide has become the second leading cause ever since 2011. And again, this pie graph is just showing the same thing. In the age group of 10 to 24 years old, unintentional injuries are 40.6%, and then suicide 19.2%, and then homicide 14.4%. So of the top three in the age group of 10 to 24, suicide is the second leading cause of death in that age group. The 2019 Youth Risk Behavior Survey, the national results showed that during the 12 months prior to taking the survey, 18.8% of high school students had seriously considered attempting suicide. And when they broke the data down between males and females, they found that 24.1% of females had seriously considered attempting suicide versus 13.3% males. In the same survey, they found that 15.7% of students had planned how they would commit suicide, and the male to female breakdown of that was 19.9% females had actually planned how they would do it versus 11.3% males. And then they found that 8.7% of students attempted suicide at least one time in the 12 months prior to taking this survey. Again, the male to female breakdown was 11% females had attempted suicide at least once in the same time period versus 6.6% males. And then they also found that 2.5% of high school students made suicide attempts severe enough to require medical attention. And the female to male breakdown was 3.3% female versus 1.7% male. And what they found in this survey results was that this is consistent with previous data that females had more suicidal ideations, more suicide plans, and more suicide attempts than males. Now this graph is just showing the percentage of high school students who attempted suicide during the 12 months before the survey overall and by sex. And so I put this in the PowerPoint just to show the top line is the female. So you see the steady incline with the female line. Then there was a little dip, which was a dip across everyone, males and females, and then a steady increase from 2017 to 2019. And that middle line is overall, and then the bottom line is the percentage of suicide attempts in males. So with looking at the Youth Risk Behavior Survey results, I also wanted to look at the results specific for Texas just to see how they compare, the results for the state of Texas compare to the national data. And what was found is that the data for Texas high school students in 2019 were very similar to the national data. And so in 18.9% of Texas high school students had seriously considered attempting suicide versus 18.8% nationally. 15% of Texas high school students had made a plan to attempt suicide versus 15.7% nationally. 10% of Texas high school students had attempted suicide versus 8.9% nationally. And then 3.4% of Texas high school students had made a suicide attempt severe enough to require medical attention versus 2.5% nationally. Now, in 2016, it was found that suffocation, firearms, and poisoning accounted for about 90% of all suicide deaths among children and adolescents ages 10 to 19. In 2016, the suicide rates for suffocation and firearms became equal. Prior to that, in 1999, firearms was nearly twice the rate of suffocation for suicide, the method of suicide. And then, like I said, by the time we got to 2016, suffocation and firearms were equal. Now, there are differences between the method of suicides between males and females. In 2016, the use of firearms was the leading method for males, whereas suffocation was the leading method for females. And then females also died by poisoning more than males. And this is just a graph showing that data. And as you can see at the beginning of the graph on the left-hand side, in 1999, suffocation and firearms, there was basically firearms was double that of suffocation. But then by the time that you get to 2016, there is equal suffocation and firearms are equal to one another as the method of suicide. And then poisoning remains at the bottom, still kind of low, but still, one of the three major methods of suicide in youth ages 10 to 19. Now, non-suicidal self-injury, or NSSI, is the deliberate act to cause self-harm without the intent to die. So examples of this would include cutting, burning, skin picking, erasing, head banging, and approximately 18% of adolescents engage in non-suicidal self-injury. The typical age of onset is around 13 to 16 years old. If you have a patient that has an earlier age of onset, so at or before 12 years old, that usually leads to more frequent and severe non-suicidal self-injury episodes. Now, risk factors for someone to engage in non-suicidal self-injury includes depression, a history of bullying, maltreatment, a poor connection with family and or friends, and then sexual gender minority. Now, non-suicidal self-injury is not specific to any diagnosis. So just because someone engages in non-suicidal self-injury, that does not necessarily mean that they have any mental health diagnosis or are depression. Because I know sometimes we have the propensity to say, oh, well, this person is depressed because they have a history of cutting, but that's not true. You can have non-suicidal self-injury and not have any mental health diagnosis and just engage in cutting behaviors or non-suicidal self-injurious behaviors. Now, data and research has shown that non-suicidal self-injury and suicide are related in some way. And so a history of non-suicidal self-injury is associated with an increased risk of suicide. The highest risk for a first suicide attempt occurs in those with a history of non-suicidal self-injury, and that risk is even higher among those who also abuse cannabis or any illicit substances along with the non-suicidal self-injury history. A history of non-suicidal self-injury also predicts future suicide attempts better than a history of previous suicide attempts. And then the risk of suicide substantially increases 1 year following treatment for an episode of non-fatal, non-suicidal self-injury. The earlier age of onset of non-suicidal self-injury has also been found to significantly increase the risk for suicide attempts as well. And so that earlier age of onset, like I said on the last slide, at or before age 12, that's definitely going to increase the risk for future suicide attempts. So after learning and hearing about this data, imperative that we screen and assess for suicide and non-suicidal self-injury. And the pediatric primary care clinic is one place where we can screen for those behaviors pretty easily. And so now I'm going to give it off to Dr. Kerr so that she can tell you all about some ways to screen for these.
Yeah, thank you, Dr. Johnson. I think Dr. Johnson did a fantastic job of kind of demonstrating why this is so important and why we're talking to you today about how to screen for and assess suicide risk in your primary care clinic. So that's what I'm going to talk about for kind of the meat of this presentation, is how to implement some of these strategies in primary care settings. So I want to start with just kind of this slide, which is just a slide showing, it's not an all-inclusive slide, and it's not specific just to the pediatric population, but these are some known risk factors for suicide. And some of these are going to be kind of intuitive, or things that you maybe are pretty commonly known, like mental illness or a previous suicide attempt. And some of these maybe are not as intuitive, like medical illness is one that I think we don't commonly think about as being a risk factor for suicide, but it is a known risk factor, as well as just highlighting in this age group between the ages of 15 and 24 is a risk factor for suicide. So our adolescent patients are walking around at a higher risk for suicide than the baseline population. So very important in this population to be thinking about and asking about suicide. And then this slide is just from a resource from SAMHSA of some suicide warning signs. Again, some of these are kind of intuitive, and you might already be thinking about or looking for in some of your patients, like talking about or wanting to die, looking for a way to kill oneself, or talking about having no reason to live. But some of these we don't necessarily immediately associate with suicide risk, like increasing alcohol or drug use may not always be a red flag for you for suicide. It may be a red flag for something, but you may not always think suicidal risk, or sleeping too little or too much. That's a common complaint in adolescents and something that may be a warning sign for increased suicide risk. So just kind of pointing out that we have a lot of risk factors that we know of, and some of them are more intuitive than others. And so sometimes clinical intuition isn't the only thing we should fall back on. And so before I talk about specifically the primary care setting, I want to take a step back and talk about suicide and suicide risk in just the medical setting in general. So suicide is one of the most frequently reported sentinel events to the Joint Commission. So this is kind of in emergency department or hospital settings. And you might be surprised to know that a large portion of these suicide sentinel events are actually occurring on non-behavioral health units. So not on psychiatric units, but on medical units. So in 2007, the Joint Commission issued National Patient Safety Goal 15, which required that all behavioral health patients be screened for suicide risk, whether they were in a psychiatric setting or the general medical setting. But in 2016, they broadened this to a recommendation in all patients in medical settings. So not just behavioral health patients, but all patients in medical settings. They recommended be screened for suicide risk using a standardized evidence-based screening tool. And some other expert organizations have also weighed in on this. The National Action Alliance for Suicide Prevention and the American Academy of Pediatrics both support implementing suicide risk screening in medical settings and increasing provider education about suicide risk. And the American Academy of Child and Adolescent Psychiatry, or ACAP, has actually created the Suicide Risk Screening Clinical Pathway, which is a guide to implementing suicide risk screening in emergency departments and inpatient medical units. So lots of expert groups are kind of weighing in and giving suggestions for how to implement this. And so the question may still be why screen? What's the benefit? So when they did root cause analyses of these suicide sentinel events that were reported to the Joint Commission, the #1 root cause of the suicide was determined to be a lack of assessment for suicide risk. We're just not doing the assessment, we're not asking. Patients are often going to present with some kind of somatic chief complaint, and they may not reveal their suicidal thoughts unless someone asks them directly. So we can't intervene unless we know, and it's seeming like we really have to ask to know because people are not telling us directly. And we also can't rely, like I said, solely on our clinical intuition or kind of evidence of suicidality to screen. We really need to be doing universal systematic screening in patients that are 10 years and older so that we're not missing anything. We're really just being universal and systematic about screening everyone. So I just talked a lot about the hospital setting, so you're probably asking yourself, well, why are you talking about primary care setting? Why are PCPs important in this? And I would point you to several studies that reveal, or a specific study that revealed that 3/4 of patients who died by suicide had contact with their primary care provider within a year of their death. And about half of those had contact within 1 month of death. And when you contrast this to contact with a mental health professional, only 1/3 of those patients had been in contact with a mental health professional in the year before their death, and only 20% within a month of their death. So patients are seeing primary care providers with an increased frequency than they are seeing mental health professionals, and that presents a very significant intervention point. Another thing that I pointed out earlier is that medical illness is a known risk factor for suicide in adults and youth. And so we know that those kids that have chronic medical illnesses are already at an elevated risk for suicide. And we also know that they're often coming into the primary care office more frequently because of their chronic medical condition. So that gives another intervention point for this higher risk population. And finally, there's just a unique relationship that primary care providers have with their patients. Oftentimes, primary care providers are seeing their patients for many years, through childhood and into adulthood, if we're talking about family practice. And they've developed a relationship with the patient and with the family that may make it more comfortable and more open for the patient to reveal these difficult thoughts with you. And again, looking back at what the experts are saying about this, so the AAP and the U.S. Preventative Services Task Force both recommend screening for mental health disorders in primary care settings in the adolescent age group 12 to 18. Unfortunately, the data on universal suicide risk screening is still really developing. And so in 2014, which again was, we're at 7 years ago now, the data was still insufficient for the U.S. Preventative Services Task Force to recommend universal suicide risk screening, but they have not recommended against it. They just said there's insufficient evidence at this time. So we're definitely should be screening for mental health disorders, and I would like to argue that we should also be screening for suicide risk in our adolescents that, again, we know are at a higher risk for suicide. So I want to just take a minute to distinguish between suicide risk screening and suicide risk assessment. So a screening tool is suicide risk screening, similar to other screening tools, is designed to identify individuals who are at risk for suicide. And it's usually brief, easy to administer, and has a high sensitivity. So you're casting a wide net, but you're really not quantifying anything about the level of risk. You're just kind of identifying who is at risk. A suicide risk assessment is designed to be used kind of in tandem with a screening tool to identify those who are truly at risk and need prompt management. And so it will kind of confirm and quantify the severity of risk, unlike the screening tool. And it's usually a more in-depth evaluation that's higher specificity. And again, these tools kind of go hand in hand with each other. I also wanted to talk a little bit about depression screening versus suicide risk screening. So as I mentioned, there's already a recommendation that we should be screening for mental health disorders universally, and depression screening tools are very common now in primary care practices. Some providers have, or there's some thought that, well, I can use my depression screening tool to also screen for suicide risk. I would encourage against that for a couple of reasons. So the depression screening tools have specifically been validated for screening for depression. They have not been validated to screen or identify suicide risk. And because of this, they may actually be they may lack both sensitivity and specificity in detecting suicide risk. That's because not all suicide attempters are clinically depressed. So that means you're going to under-detect people who have suicide, who are at risk for suicide but are not depressed. And also, not all patients with depressions have suicidal thoughts or behaviors. So you're going to over-detect in the depressed population because not everyone who is depressed is going to attempt suicide. So just to further kind of more concrete example, the PHQ-9 or the PHQ-OA is a very commonly used depression screener in primary care, both adult and pediatric situations, and it's a good tool for depression screening. Sometimes people look at question 9 of that tool, which is asking about thoughts that you would be better off dead or of hurting yourself. And some people use that as a suicide screen. Like if they screen positive on this, and this is a suicide screen. However, I would argue that question is not, it's ambiguous and it's not specific enough. So thoughts of death is a really ambiguous phrase, and it could be common in patients who have chronic medical conditions, who have a terminal illness, where death is a reality. It is something they might be thinking of. So thoughts of death is just really vague, and I don't think it gets at really what we're trying to screen for. And then when we include that "or hurting yourself" phrase, that may not be specific enough, because we're going to capture, especially in adolescents, patients who are engaging in non-suicidal self-injury, which, yes, is a risk factor for suicide, but not all adolescents who are engaging in non-suicidal self-injury actually are having suicidal ideation. So it's not specific enough of a question. It may be including more and then overburdening you as a screener. So just to further demonstrate this point, Lanzio and colleagues in 2017 did a study where they screened medical inpatients using both the PHQ-A and a validated suicide risk screening tool. And they showed that if they just used the PHQ-A to screen for suicide risk, they would have failed to identify over a quarter of youth at risk for suicide. And that's too many. That's missing too many. So I would just encourage you, if you're using question 9 as kind of your suicide risk screen, to maybe think about changing how you think about question 9 in the PHQ-9. So if you wanted to screen in your practice setting, there's 2 main ways. One is the clinical interview, and I've included 2 acronyms here that are just kind of the psychosocial part of the interview that are designed to hit at some of those risk factors that I showed before. So SHADES is one that's been promoted by the AAP, which stands for strengths, school, home, activities, drug or substance abuse, emotions, eating, depression, sexuality, and safety. And then HEADS is actually the acronym that I learned in my residency training: home, education and employment, activities, drugs, sexuality, and then suicide or depression. The nice thing about just asking these questions in your clinical interview is that you don't have to worry about if the tools that you're using are accessible to your patient population, like if they're at a reading level that most people will be able to read, or if you're going to use an app, if the family has an access to a smartphone. So that is a nice thing, but I would, again, these may be more, they may take up more time, which I know is short in primary care offices, and you may, it may be, it's easy to forget to ask one of the questions, or, to breeze over this and miss something. So I would argue for using a standardized screening tool. There are various forms of these. Some are self-report, some are provider asked, some come in paper pen, some are, again, like on a computer or a mobile app. And a nice thing about several of these tools is that they could potentially be given by a member of the clinic staff before the provider even enters the room. So it's already been administered. It's not taking time out of your short, brief visit like a clinical interview might. And then you could also potentially integrate this into your EMR. So I'm going to talk the most today about the Ask Suicide Screening Questions suicide risk screening tool, because this is the tool that the ACAP is using in their suicide risk screening clinical pathway, and it was developed by the NIMH. I'm going to mention a couple other tools, but I'm just not going to talk about them quite as much as this one. So this tool is a provider asked questionnaire, and it has 4 items that take about a minute to administer, and then if they answer yes on any of those items, then there is a 5th question that's kind of designed to get at like acute risk. It's available for free on the NIMH website, which is another reason why I think it's a great tool. And on the website, there's also a toolkit with resources about how you can, specifics of how you would implement it into your practice, and also some parent guardian education tools. This, the ASQ was originally developed and validated in the pediatric emergency department setting, and there it demonstrated a sensitivity of 97% and a specificity of 87%, with a negative predictive value of 99.7 in medical surgical patients and 96.9 for psychiatric patients. So that's a pretty strong negative predictive value and can make you feel good about it as a screening tool when you're ruling people out. They're currently in the process of validating this for inpatient and outpatient medical settings. The data is promising, but they haven't published it yet. And the nice thing too about this tool, I'm going to go back and show you, it shows it gives you prompts for the next step. So if they answer yes, what do you do next, which I think is really helpful, especially in people who are not mental health experts, and this is not the most comfortable topic to be dealing with. Briefly going over a couple other options. So the Columbia Suicide Severity Rating Scale, or the Columbia is what it's colloquially called at, is a full risk assessment tool that's been validated across several settings in children, adolescents, adults, and it's used in lots of hospital settings. The people who made this screener, or they made this the severity rating scale, they also made a shorter 5-question screening version that's based off of the full risk assessment tool, but it's only 5 questions, and it's meant to be more of a screener rather than a risk assessment. This tool, the screening tool, has not been validated in pediatric. The full risk assessment tool has been, but just knowing that the screening tool specifically has not been validated. But the Columbia system also has a website with resources on how to implement in primary care offices that's really helpful. And I have a slide at the end with the links to these websites, so I'll show it at the end. There's also the Suicide Behaviors Questionnaire, which is a 4-item questionnaire that kind of focuses on past suicidal thoughts and attempts. There's a behavioral health screen that's web-based. It takes about 7 minutes for the patient to complete. And then there's a suicidal ideation questionnaire, which is used a lot in some of the research studies. The self-report tool that focuses on suicidal ideation. It takes about 10 minutes to administer and 10 minutes to score. They have a 15 to 18-year-old version and then a 12 to 14 version. And this one comes in paper, pencil, or computer, so you can kind of use what's best in your office. And so now that we've talked about screening tools, what do we do if the screening tools are positive? The next step would be risk assessment. And I'm specifically going to talk about the recommendations from the Suicide Prevention Toolkit, which I have a link to at the end. This is a really great resource for, it's a toolkit of resources to how to implement kind of the things we're talking about today into primary care offices. And they identify 4 key components of a suicide risk assessment. The first is assessing for warning signs and risk factors. So we kind of already briefly touched on those. Also assessing protective factors. Those are important to consider. Then doing a true suicide inquiry and asking not just about thoughts, but about plan, intent, and access to means. And then the last piece is clinical judgment. So the Brief Suicide Safety Assessment, or the BSSA, is a risk assessment tool that was designed to be used in conjunction with the ASQ that I talked about earlier. So it's designed to help triage patients who screen positive on the ASQ, because not everyone who screens positive is going to need an immediate psychiatric consultation or an immediate hospitalization. So this tool is designed to help you figure out, okay, they've said yes, they've screened yes, now what do we do next? This can be completed in about 15 minutes, and there's a worksheet. What I really like about this tool is that it gives examples of how to ask these assessment questions, because if this is not an area that you are asking about frequently or that you're very comfortable with, it can be hard to figure out how to phrase the questions, and so this is really helpful. And again, this tool is based on evidence. The risk factors and the protective factors that you're asking about in this tool are evidence-based, but they haven't done the studies specifically with this tool. And some other tools are the Columbia Risk Assessment tool that I alluded to earlier. It's freely available, and it's designed to measure the severity of suicidal ideation and behavior. They've used and validated this in adults and adolescents, and it's been found in studies to predict short-term suicidal behavior in high-risk adolescents. It's very commonly used in hospital settings, and there is a website for kind of how to implement this. And then the Suicide Assessment 5-Step Evaluation and Triage is another tool that was developed by SAMHSA and the Suicide Prevention Resource Center. It's based on the American Psychiatric Association's practice guidelines. And there's a pocket PDF card that I'm going to show you on the next slide that you can get online for free. And there's also a mobile app that can help with the assessment as well. It's based, like I said, on the APA's practice parameters, which are evidence and expert-based kind of recommendations, but they haven't done published studies specifically on this tool. Like, as I mentioned, the same thing with the BSSA. So they're kind of developed on a strong evidence base, but they haven't done the studies specifically using these tools yet. This is just the picture of that safety pocket card that I mentioned that the Suicide Prevention Resource Center has available. Over here you have kind of your risk factors and protective factors to kind of remind you, and then it helps break down into high risk cases, moderate risk, and low risk. Kind of tells you a broad overview of what would be in that, having a plan with preparatory behavior versus having thoughts but no real intent or clear plan versus just really having thoughts of death and no plan or behavior. I wanted to point out in the high risk and moderate risk, one of the things they talk about is safety planning. So if you'll notice, only this one, I know the font is kind of small, but this one category over here is the only one where it says hospitalized. In this lower tier of high risk and moderate risk, it talks about safety planning. So I want to take a minute to talk about safety planning and kind of what that is and how you can use that in your practice. But before I talk about safety planning, I want to talk about non-suicidal self-injury and a risk assessment tool for non-suicidal self-injury, because again, this is very common in the adolescent population, and it is a risk factor for suicide attempts. So SOARS is a brief screening and assessment tool for non-suicidal self-injury that was developed by some researchers at the University of Texas Southwestern in Dallas. It stands for suicidal ideation, onset, frequency, and methods, aftercare, reasons, and state of change. And I think this is just a nice way. There's a pocket card available for this as well that has kind of the questions that you would ask for each of those letters of the acronym. But I think that it's important. One of the things that, it seems obvious to ask about suicidal ideation and kind of onset and frequency. I think those are things we intuitively think to ask about. But one thing you might not always think about asking is aftercare. What are the patients doing to take care of their wounds after? And have they ever had wounds that are so severe that they need to seek medical intervention for them? And then reasons is another important thing to think about. Not every kid who's doing non-suicidal self-injury is having suicidal ideation. Some reasons that they may engage in these behaviors are as a coping mechanism to distract them from disturbing thoughts, negative thoughts, not necessarily thoughts about wanting to kill themselves, but other kind of distressing thoughts. It may be kind of a cry for help to get people to realize that they're struggling, and various other reasons. So it's not always, sometimes it is to prevent themselves from acting on their suicidal thoughts, but there are also other reasons, and it's important to ask about those. And then, so finally, I just want to talk about safety plans. And first, I want to distinguish between a safety plan and a no suicide contract. So a no suicide contract is when you ask the patient to pledge either in writing or verbally that they won't do anything to kill themselves. And this is not evidence-based. There's nothing that's been shown that if you have a patient sign one of these pledges or verbally give a pledge that this will reduce suicide or suicidal behavior, and it may serve as like a false sense of security for the provider. That's just really not evidence-based. So we do not recommend no suicide contracts. But we do recommend safety planning, which is an individualized plan where you get input from the adolescent or the child and the parents to develop kind of a plan and steps that the patient can use when they're in a crisis, when they're having an emotional trigger. And it's meant to be kind of written out or put it on their phone, something that they carry with them so that when they're in that crisis situation, they can reference it. And then also referencing it throughout the course of treatment, whether that's with you or with their therapist, kind of going back and looking at it and how is it working and what tweaks need to be made. So Safety Planning Intervention, or SPI, is a specific safety planning approach that was named a national best practice for suicide prevention. It's designed to be comprehensive yet brief, so 20 to 45 minutes. Maybe this is something if your clinic has a social worker or a case manager that maybe another staff member could help with. And there are 6 main elements of the safety plan. So first is recognizing signs that the symptoms are worsening, initiating coping strategies, making use of social contacts to help distract from thoughts of suicide, contacting family members to help deal with the crisis, contacting mental health professionals.
How did your Spanish thing go? I don't know yet. Oh, no.
If you could mute.
Was that the
contacting mental health professionals, and then reducing access to lethal means. So this safety plan is meant to be a stepped process. So if the first step doesn't work, they go to the next one. So if our coping strategies are not working, then we reach out to our social contacts and try and use that. If that's not working, then we reach out to family members, adults that can help us deal with the crisis. And there's a website for this as well. So the last thing I want to talk about before handing over to Dr. Blood is barriers, because I know that there's a lot that I just threw at you, and there's probably a lot of concern about how feasible is this. And I know the biggest one is probably, how do I safely manage patients who screen positive? If I ask about this, how do I safely deal with this? So what I would say to that is a positive screen is a sign that's a symptom that needs further evaluation. So just like when we take a blood pressure and maybe it's elevated, we don't immediately call the nephrologist or start the kid on a blood pressure medicine. We might wait, 20 minutes, see if they calm down. We might check to make sure the blood pressure cuff is the appropriate size. We evaluate further that symptom. And the same thing goes with the suicide screen. We may have a positive screen, we evaluate it further and see what the appropriate next steps are. That may not be immediately referring to an inpatient hospital. The other point is that symptom is present whether we ask about it or not. So that child is struggling with suicidal ideation whether we ask about it or not. But if we don't ask about it, we don't have the opportunity to intervene and help. So I think it's still really important that we ask, even though we know that the system is not ideal and there are still a lot of areas that need to be improved. There's also a myth about iatrogenic risk, that if we ask about it, we're going to put this idea in the patient's mind, even if they weren't having it before. There's been a lot of studies that refute this, that if we ask about suicide, that it's going to plant that seed in a child's mind. In fact, there's some studies that adolescents actually like maybe not the word, but they feel like someone cares when they ask that question. And then suicide is a low base rate event, so it's really hard to develop instruments that accurately predict suicide just because of the low base rate of it happening. But while we don't have tools to predict, very specifically which youth will die by suicide, we do have tools to detect suicidal ideation and tools to look at other suicide risk factors, and that is an intervention point. Approximately a third of youth with suicidal ideation will develop a plan in adolescence, and 60% of those who develop a plan will attempt suicide. So if we can intervene at the point where they're having suicidal ideation, we may stop that process of developing to a plan and then to a suicide attempt. And the last and very fair barrier, I think, is that we're already asking primary care providers to do a lot in a little amount of time. And I totally understand that. And, that's part of why I suggest the screening tools that may be briefer and that could potentially be administered by someone else and not take out of your, the time. And as far as mental health resources, we know this is a big challenge, but I'm going to turn it over to Dr. Blood, who's going to talk to you about a resource here in Northeast Texas that hopefully will help with identifying mental health resources for patients that you screen positive or need help with.
All right, thank you, Dr. Kerr and Dr. Johnson. So what I want to talk to you all about today is CPAN, the Child Psychiatry Access Network. And so CPAN has a threefold system to help primary care providers treat adolescents and children. And so what I want to focus on is how we can help in this specific topic, dealing with suicidal patients. So specifically, we offer support, coordination of care for patients who need follow-up, but we also can help support your clinic as well. We specifically have resources on the safety planning guides. We have templates for patient safety plans, and we also can help develop a crisis protocol. So a crisis protocol is a specific written instructions on how you and your office will address a mental health crisis when it arises, and the protocol will assist you and your staff and patients by providing a predictable, consistent response to patients who may present with a mental health crisis. So these are some of the supports that we can additionally provide along this topic that we're presenting today. But in general, CPAN offers a child psychiatry consult service, which is a conversation directly over the phone with one of the child psychiatrists in the CPAN program, and we are just 3 of those psychiatrists. We also can consult you on non-pharmacological interventions, and we can talk about medications, we can talk about diagnosis and possible other recommendations that may need to come up in general about these kiddos. And the great thing is that there's no limit on the number of calls that you can make. So this is the service area in these 25 counties in the Northeast Texas. This is our this is the area that we cover. And so when can you call for our services? Basically anytime. We're here 8 to 5, Monday through Friday, except for holidays. So if you're like me and you get to the office early and you kind of run through your list of patients and you say, okay, well, this is a question I have, you know, you can call then. If something comes up during the evaluation or the exam that you want to call us right then and there, that's perfectly acceptable. And then after they leave, or when the time when parents call, they'll leave you a message or they call in crisis and they need something, you can call us really anytime. And so these are the things that we would like to kind of know. So these are the 5 S's. Safety, and this is kind of what our presentation has been revolved around today. So are there any concerns with the patient's safety? What behaviors are causing these complaints? What setting is this happening? Is it school, at home, both, or other specific places? What stressors are going on with the child? Divorce, family, school, bullying, stuff like that. And then also we need to know what services have been used in the past. If they've been in therapy before, if you tried them on medications, or if they've previously seen a psychiatrist, or things like that. And so we provide quite a few assessments and screening tools. This is a very brief list of the ones that we provide. And we can talk to you about these specific screening tools. If you use them and you're not sure how to interpret it, we can help with that. If you want to know which one to use in certain types of situations, we can also help with that as well. But these are just some of the basic ones that we provide, and that is not an all-inclusive list either. And so what do you do? So technically you don't have to be registered to use the service, but registering allows us to track the patients that you call. So if you ever call back on a patient, we can bring that patient back up in the system, and helps us remember what we talked about last time and what our recommendations were. So you can register by phone, just by calling the CPAN number, and you just answer a few calls to get registered. You can do that after you've utilized the service. You don't have to do it the first time. It's really easy to do. And so you just call us, you talk, one of our therapists will be the ones answering the phone. They'll take the call and then ask you a couple questions to kind of understand what's going on. And then if you need to talk to one of the psychiatrists, then you'll receive a call back within 30 minutes. That's the state standard. We're pretty good about doing it within 10 minutes. So, and typically our calls are lasting no more than 10 minutes. And so we're on the phone giving this consultation in under 10 minutes. So if you have those few minutes to spare, we're more than willing to help you.
And this is just the list of the resources I was talking about earlier. So I'll leave this up while we answer questions so that you guys could copy some of this down and try and figure out if I can. There we go. So I don't know if it's really hard to see questions when the presentation is going, so I don't know if we have some already that people wanted to ask.
I have a question.
Yeah.
Are there any specific studies for the no suicide contracts where they found that it wasn't effective, or there are just no studies showing whether it's one way or the other?
There are studies that they have shown that it's not effective.
Oh, okay, gotcha. All right, that makes sense. Thanks.
Dr. Kerr, in the chat, someone said, can you talk a little bit more on how to use the ASQ BSSA if we get a positive ASQ?
Yeah, so let me see if I can go back to that slide and pull it up. It has questions that you kind of use to, and I only did the first sheet, and the website will have kind of the protocol of how to kind of triage it out, but basically it has you ask more specific questions, like on this one specifically asking more about the frequency of suicidal thoughts, the suicidal plan, and the past behavior. And then there is a kind of a second part to this page that kind of helps you triage it out based on kind of what they tell you on these more specific questions.
There was a question asked earlier in the group, but I think it was answered, but we can go back over it just to maybe have some discussion. Somebody asked, why do individuals engage in cutting behaviors if they do not have a mental health diagnosis? I'm not sure if I fully understand if you mean they don't have a mental health diagnosis per se, or they wouldn't meet criteria for a mental health diagnosis. Some adolescents engage in all sorts of behaviors for various reasons. I would say probably the majority of children engaging in non-suicidal self-injury do have a mental health concern or would meet criteria for a diagnosis, but often they just have not been identified yet. That was some of the barriers that were mentioned earlier. But there are kids that just do certain things to fit in, or impulsively thinking, do things in a group setting to make a joke or to get influence. So, you know, kids can do it for other reasons besides mental health reasons. But I would say again that a fair amount of them would meet criteria for a mental health diagnosis if they already haven't been established.
Well, I think I'm gonna, if there's not any more questions, I'm gonna stop sharing my screen so that we can put up the QR code so people can get credit. I can figure out how to stop. There we go. And Lori Connors, I saw your comment about screening the PHQ-9 at every visit from 12 up, whether it's sick or well. And I agree, it's a step forward. I know that it's kind of asking a lot to do the suicide screening. I think what I would give as a goal for everyone leaving this is not that you have to go start this right now in your practice, but think about what steps what little steps you can take to be doing more screening. And even if it's the PHQ-9, that's better than nothing. So I think you know, just opening your eyes and kind of pointing out some other resources as well.
I have a quick question. Is there any evidence for like any value for like motivational style of interviewing or intervention for these folks? Because for people who have suicidal tendencies, because I found at least anecdotally in my personal experience, sometimes just like asking, you know, how willing are you to do X, Y, or Z to call for someone for help from 0 to 10. That seems to be more helpful for the patient rather than just saying, asking them to write things out, because like I have no idea what if I can trust them or not unless I have a scale like that. So I'm just curious what your experience is like with that, or if there's any evidence through papers or anything else that people have found in terms of motivational style of approaches for suicidal patients.
Yeah, so I don't know. I would say there's definitely a lot of evidence about motivational interviewing, and we had a presentation recently on motivational interviewing. I don't know specifically, I didn't research that for this presentation specifically about motivational interviewing in this setting, but I think that there's evidence that it is helpful in other settings, and I can see where it would be definitely a useful tool in this if it's something that you're familiar with and use frequently.
I would add that it can be very beneficial, motivational interviewing, for non-suicidal self-injury. You know, motivational interviewing is an aspect to promote change and to get them to think about making changes. And so if they're constantly self-injuring, then that would be something that would be a positive change. But yes, also for suicidal thinking, if they continually are thinking about not using their coping skills and are just falling on to suicidal ideations, then motivational interviewing can be beneficial in helping them make the changes of using coping skills instead of reverting to suicidal thoughts. There was another question in the chat. What evidence do you have for pearls on safety planning, home discharges, on the aspects of coordination with parents? And how frequently would you follow up with these patients?
So safety planning with home discharges and especially with coordination with parents, I think a big, I didn't go into a whole lot of the specifics of how to come up with the safety plan, but a big aspect of the safety plan is making sure that the parents are willing to be a part of it too. You have to assess kind of parents willing to kind of supervise or reduce access to means or things like that. So if you're not getting a great sense that parents are willing to kind of buy in, that may be a risk assessment where you lean more towards more restrictive care like inpatient hospitalization or emergency department. And then frequently following up, I would say if you're talking about discharge home from the hospital, I usually like them to have an appointment kind of within a couple days with at least some sort of provider, whether that's a therapist or their primary care provider or their psychiatrist, somebody within a couple of days to just check in and see how things are going.
Yeah, I echo that. You do want frequent follow-up because discharging is one of the highest times for suicide attempts, is following a discharge.